Hello everyone. Today we will discuss about Meconium Aspiration Syndrome. So this is an important aspect which you have to deal especially in preterm babies as well as in your routine pediatric NICU setups. Meconium Aspiration Syndrome is a respiratory disorder of the newborn caused by inhalation of meconium-stained amniotic fluid. It is a major cause of respiratory distress in term as well as in preterm neonates. It may lead to hypoxia, surfactant inactivation, and pulmonary hypertension. Meconium forms by 12 weeks of gestation and is the first intestinal discharge of the fetus, normally retained due to the anal sphincter tone and passed after birth within the first 24 to 48 hours. Meconium is usually composed of intestinal epithelial cells, bile pigments, mucus, langohair, vernix caseae, pancreatic secretions, and water. Fetal hypoxia or stress stimulates the vagal activity, intestinal peristalsis, and anal sphincter relaxation. Meconium is expelled into amniotic fluid. The fetus may gasp into in utero and aspirate meconium-stained fluid into the lungs. Maternal causes include postpartum pregnancy like placental aging, maternal hypertension and preeclampsia, diabetes mellitus, prolonged or obstructed labor, oligohydramnias, and smoking, drug abuse, or infection. Fetal causes include fetal distress or asphyxia, which is the most common cause, umbilical cord compression, intrauterine growth restriction, post-term maturity of the GA tract, intrauterine infection, and inflammatory stress. Pathophysiology of Meconium aspiration syndrome, there will be airway obstruction resulting in hyperinflation and atelectasis. Chemical pneumonitis due to bile salts and enzymes. Surfactant inactivation leading to alveolar collapse, which in turn causes hypoxia-induced pulmonary vasoconstriction. Air leak syndromes causes pneumothorax, pneumomediastinum. In the brain, it causes hypoxic ischemic encephalopathy. In the heart, it causes myocardial dysfunction. Kidney, it causes acute tubular necrosis. In the liver and gut, it causes ischemic injury due to hypoperfusion. Clinical features include respiratory distress soon after birth, tachypnea, cyanosis, grunting, and retractions, a barrel-shaped chest due to air trapping, and choirs, crackles, and a rhonchi on auscultation. Signs of pulmonary hypertension in severe cases. Investigations include chest X-ray for patchy infiltrates, hyperinflation, and atelectasis. In ABG, it causes hypoxemia, hypercapnia, and acidosis. In echocardiography, to assess the pulmonary pressure and rule out any anomalies. CBC and CRP to rule out any infections. So this is the image of a meconium aspiration syndrome where patchy infiltrates, hyperinflation, and atelectasis. Diagnosis is mainly clinical, supported by meconium-stained amniotic fluid at birth, respiratory distress developing soon after delivery, radiological finding consistent with meconium aspiration syndrome, exclusion of other causes like congenital pneumonia or hyaline membrane disease. Differential diagnosis include transient tachypnea of the newborn, hyaline membrane disease, especially in preterm, neonatal pneumonia or sepsis, persistent pulmonary hypertension, congenital diaphragmatic health. First, delivery room care, clear the airway if baby is non-vigorous and avoid aggressive suctioning. In NICU, oxygen, CPAP or ventilation support, surfactant therapy, antibiotics and fluids, and inhaled nitric oxide or ECMO if refractory. Long-term prognosis, survival is greater than 90% with modern care. Some may develop a chronic lung diseases or bronchopulmonary dysplasia. Others may have recurrent wheezing or asthma-like illness. Risk of neurodevelopmental delay in severe cases. Good antenatal and intrapartum monitoring, avoiding post-term pregnancy and early detection and management of fetal distress are preventable causes, and meconium aspiration syndrome is preventable with vigilant obstetric and neonatal care. I hope you learned through this presentation. Thank you for watching.